A round of applause for Professor Louise Newman.
Okay, that's good. Thank you. Thank you very much to ASH for inviting me here and flying me up, even though the plane was 1 3/4 hours late. However, that's how we cope at the moment. But it's really great to be here and have a chance to meet people. Usually we're talking on the phone or online and so on, so it's really nice to... And some people I have crossed paths with, of course, over the years. So I'm a psychiatrist. I'm currently doing some practice largely in the areas of trauma-related mental disorder, the consequences of trauma of various sorts. I'm also a child psychiatrist, so I do see children who've suffered quite significant trauma. I work in several jurisdictions on those sort of matters, including criminal matters where action is taken against perpetrators in order to protect children. So none of it is particularly, how can I say, it's all very important work from my perspective, but it's quite draining and difficult work to do. So I do have a few other things that I see which are maybe not quite as draining as trauma. But I thought for the purposes of giving a bit of an overview today of some of the issues in working on these sorts of matters, regardless of from what perspective. Certainly in family law, there are many and quite complex cases where children are obviously caught up in the conflicts, which can be seemingly endless. My record to date is a particular case in another state where parents of children are still fighting over custody and related, there's financial issues, there's custody issues, and counter allegations, cross allegations about who was the worst behaved and harmed the children. This has been going on for 12 years, seemingly without resolution. So I think these cases, largely because they're so emotionally draining and complicated, and many of the parents who might be involved in this sort of work have themselves come, as people here would be well aware, from really complex backgrounds of their own abuse. And that's really what we talk about, thinking about transgenerational themes. And courts, unfortunately, and this is maybe putting it a bit strongly, but I think it's important to think about what does the court become? And in many ways, sometimes the court, particularly family court, but not only, is like an arena for the enactment of battles that the parties, in many cases, the aim is not resolution and solving of the matter and coming to a peaceful, it's like Trump's board of peace, isn't it? There are hidden aims, and the aim is not necessarily coming up with solutions and resolution. And I can always remember many years ago when I was first doing this sort of work, probably about 30 years, which is awful, isn't it, but true. A little lad, I asked this little boy, what did he do? And he said, well, I don't do anything. He was about 6. I said, well, what's the main thing that you do in your life? He said, I go to the family court. And that's how he defined himself. Even though, of course, he didn't go to the court, which raises other sorts of issues about how much consultation children do benefit from. I think it's something that could be worked on. And the complex issues in his family were about 2 highly traumatised parents who had really no clear intent in resolving their matters. They were full of anger, unresolved trauma, and it needed to continue as far as they were concerned. And they successfully done that. The costs, of course, are immense, financial costs, but emotional costs as well. So transgenerational themes occur in a lot of this work, and I think in my experience in going through several courts, whether it's children's court or we're looking at higher level courts, whether it's family law or abuse, there are issues that do come up repeatedly in cross-examination. Now, as a psychiatrist, being cross-examined, I think it's something that we come to understand in the same way that maybe the legal system has come better to dialogue with psychiatry and mental health. So there are still tensions in the way that we describe things, in the way that questioning and cross-examination can continue, and some issues are very controversial, particularly let's say the issue of psychiatric diagnosis, the common issues that people, which I will say a little bit about, become really quite animated about, is the diagnosis of so-called personality disorder. So I thought I'd just tackle that at the beginning of this, and whether the DSM system, the Diagnostic and Statistical Manual of the American Psychiatric Association, is truly written on stone, or if there are alternatives. And I've been cross-examined on that issue, which went on. It was in a complex issue. And I think these things, I always put them in reports to try and prevent unnecessary cross-examination and waste of time, essentially. But that's not always successful. So I think in some ways, sometimes we speak slightly different languages, frustrating for both sides. Some of the, in some of the cases, we're asked to make very clear pronouncements about treatment. In what length of time will someone show this percentage of improvement? And I'm sort of just say, well, it depends, which is infuriating and enraging for the system, but that is actually true. There are multifactorial issues that impact outcome as well as diagnosis, so you can get several contesting psychiatric experts with different diagnoses, all of which can be argued and might be quite plausible. So sometimes it's useful to take a step back from that sort of skirmish, given that the DSM and other psychiatric systems are not actually, they're guides. They're clinical opinions and they're guides to standardised language. They are not a test of whether someone does in fact have the condition or not. So it gets, I think, sometimes a bit muddied, but I think the issue, when court goes well, there can be really sensible and balanced discussion about why the complexity happens. Why is it that I might say, well, as I had to, in a matter I'm involved with, say to the system yesterday, you're asking me about what's going to happen for this particular person in the immediate term. Can they be made safe and show improvement? The medium term, then the long term. And what are the implications of those timelines? And you haven't provided a timeline. And I think then we get a little bit at cross purposes when I can outline what sort of factors should a report address that's going to make it useful for the court or for child protection or whoever we're talking about. It has to be practical. So I always like, to develop a staged plan. And I think if you're reviewing reports, as you obviously do, it's sometimes helpful to look for what a plan might be. So I'll cover some of that territory, as I've said here. I think the other thing just to note is that the field of trauma, like any other field, is probably, in my perspective, having done this now for a while, does not have the same kudos maybe or appeal for young practitioners as it should. And I think that's partly my profession needing to have better training and exposure for young psychiatrists, particularly to see just how pervasive histories of trauma, neglect, abuse are in people with psychiatric disorder of all kinds. So essentially a history of trauma is a non-specific risk factor for a whole range of traumatic experiences. The other issues that I work in that are also sadly perhaps not addressed to the extent that they should and are a subject of great media and community interest at the moment are questions of women's mental health, and particularly the interactions between hormones, mood disorder. If we look at something like PMDD, premenstrual dysphoria, we're looking at the menopause and the issues that relate to mood changes there. And there's a lot of public discussion at the moment about endometriosis, and I think that these are going to result in quite understandably many claims, some of which allegedly at the moment are being thought of as more as malpractice, but it's also bigger than that, in my opinion. I think it's a cultural and systemic issue where, particularly for women, complaining of mental changes, psychological issues, distress, pain, and some of the research is really quite strong that medical profession on the whole, whether it's gynecologists or others, tend to dismiss women's complaints of pain, which can be quite disabling pain, particularly endometriosis, with assumptions that women are somehow hysterical in the model of ancient Greece, or having conversion disorders, as you know, in the time of Freud and Charcot, we saw the grand hysterics. There's no doubt that these women are suffering, are depressed, and these things again have got multiple and complex causes. Interestingly, many of these conditions and their consequences are more common in women who've experienced sexual and other forms of abuse in childhood. And that's telling us something very important if we look at the current science about the effects of early trauma on brain development, which I'll mention briefly, but the way in which trauma sets up certain patterns in the developing brain and is also linked to poor stress regulation overall, persisting stress symptoms and hormonal dysregulation. So the more we find out about the science, the more we should be able to apply it. It's probably not happening enough. And some of that, at least if we look at how women suffering with these conditions view them and their treatment at the moment, are particularly serious. They're becoming more appropriately outspoken about that. So I can certainly see a need for upskilling for all the professions and professionals involved in these sorts of claims on these sorts of conditions. It's not going away. In fact, it's probably becoming more significant. So these in terms of themes were the main, if I get through them, but we'll have some time for questions at the end. But essentially, this area is, again, like most things people give talks about, it's big, it covers a lot of territory, and I think it's probably gaining in importance as people are more, women particularly, are more empowered around the issues. I'm often in the situation of being asked to evaluate parents and so-called parenting risk. So the sorts of parents who come from these awfully traumatic backgrounds. I'll give a case example of this as we go through, but essentially the sorts of parents who themselves have suffered abuse, neglect, and have a range of psychological and emotional issues related to that. They usually pick up a diagnosis somewhere of having some sort of personality disorder, which is often not a useful diagnosis without explanation, but they have long-term difficulties in functioning in terms of regulating their own emotions, understanding their self-experiences. They have post-traumatic stress symptoms, so trauma lives on in their lives, and we increasingly see people self-medicating with various substances to try and get rid of that. Children are in those environments are frequently neglected. They're certainly at risk of both direct physical, sexual and emotional abuse. Their attachment relationships are disrupted. So essentially we're looking at the next generation. I have seen a 4-generation family with these sorts of themes. And it's not uncommon because these are transgenerational patterns for people who essentially have not engaged in treatment. They don't believe that they want that. They're enraged, angry when they might end up in children's court or child protection services. But the question put to the experts is about what can be done in these situations. Do we have therapeutic interventions? To which the answer is yes, but only if people accept that. And there are some who don't. Do therapeutic interventions work? Yes, they can, but they're long-term. What about short-term? If we send people to a parenting course. So I think, the system has its own brief interventions, and there's not much in the way of evidence that they actually change these deeply troubled families who would take up the majority of resources within child protection as well as the legal system. These types of high-risk parents, so-called, can end up with multiple psychiatric diagnoses. I personally think the language is not helpful. And talking to many of these people with these experiences, I won't use the colourful language of a recent woman I was talking to who said she didn't find the expletive deleted language that got put to her of having PTSD and anxiety disorder and ADHD. She's had a string of diagnoses since early adolescence to young adulthood. Didn't like the language because no one asked her, what happened to you? It's more that sort of still rather reductionist model of asking, well, what's wrong with you? She knew what her symptoms were, and she was very much able to articulate what was happening to her. She just wanted it to stop and had become addicted to opiates as a result of that. And again, we're seeing behavioural disturbance, when people are engaging in self-harm, impulsivity, aggressivity, and poor regulation of emotions. That cluster of difficulties is a post-traumatic mental disorder. Yes, it's both psychological and neurochemical. Most disorders actually are. And sometimes using a string of labels. So I have the joy of going through medical records and all the psychiatric documentation on some of these cases that have started since they were first seen in childhood, in child and adolescent mental health services. And it's almost as if the story hasn't been put together. And sometimes what the clients are actually asking for is a way to understand their experience when they don't have the language for it, which is another very common experience. So these are hard to communicate, these sorts of themes, in an assessment report that's going to court. However, I've sort of taken that on as something I think is important if we're going to improve dialogue, understanding and better management of court process and legal outcome. But the tragedy of these sorts of conditions is that they can repeat through the generations. So the label of personality disorder is highly controversial. There are some consumers of mental health services who like the diagnosis, particularly of borderline personality disorder, which I'll say a bit about, because they feel someone at least is acknowledging that they face difficulties in these common areas as mentioned here. So in patterns of thinking and understanding, ways of understanding the self or having difficulties in understanding their own emotions, reactions, chronic difficulties in interpersonal behaviour, and which is complex and disorganising for people's thinking processes about themselves. So just from that description, I think it's clearly something that we don't have immediate fixes for. There are some therapeutic programs, particularly designed and targeting people with severe disorders, which you might have come across in reports, dialectical behaviour therapy being one, or trauma-focused, cognitive behaviour therapy. Now, they can help to a certain degree. They're hard to access. The mental health system doesn't have enough people doing that, particularly DBT, which would be the gold standard. In Victoria, it's only existing in the private sector. And the people we're seeing who have multiple traumas and abuse histories do not have private health insurance at the current rates. So they get no access, largely to a whole range of treatment. So we need in our reports, and I'd be looking at reports that are done on these complex cases and seeing if these sort of areas are covered, how parents' own personality as shaped by their own upbringing and abuse and trauma experiences, if there has impacted them as they've struggled to become parents. Particularly highlighted when you might be looking at cases where people started having multiple children very early. Teenagers, often as the result of exploitative or sexual assault, or sometimes kids who are living on the street have left abusive environments. So some of the clients I might see in child protection could be in their early 20s and have 3 or 4 children removed. Now this is a major failing on so many levels. We also then see the impact of this on children who've frequently been exposed to a whole range of things without being too graphic about it, but conflict between warring parties, drug-affected individuals. Some have been essentially prostituted and exploited, and on it goes. And this is why I say the emotional territory is very hard to deal with. However, if these cases do come before the court, I think there are many opportunities. They're often going to multiple jurisdictions, of course, because of the complexity of it, and some criminal matters. So a parent's capacity to parent depends on their own, in part, their own capacity to manage what happened to them and to have developed those core skills. It's probably a bit more than just saying, I really want to get it right this time. That's tragic when we see, as you might have come across, people who have had all these multiple removals of children, multiple failures, gross neglect, parents who can't have any empathic understanding. They're really struggling to understand what their children need. And so they essentially, yes, they feel failures. That fuels their drug use even further, which is a very common pattern. But they still make attempts. I mean, I think they should be given credit for that, making attempts to comply with sometimes quite hard to comply with, to put it bluntly, requirements of child protection authorities and so on. And they can become oppositional and decide not to. So this is when the system flounders. the system's not clear how to respond to some of these sorts of matters. So what we're frequently seeing is that pattern of repetitive trauma, and the youngest generation are frequently in alternative care. If they're lucky, it's kinship care arrangements, but they are not necessarily benign given the history of some of these individuals, and that's a complex issue as well. Borderline personality disorder, which I'm sure you hear about, just to say very briefly, it covers a spectrum of difficulties, but relating to development of self-regulation, emotional understanding, and it's very much in the DSM system, Diagnostic and Statistical Manual, focuses on mood instability, impulsivity, and interpersonal difficulties. So we see a cluster of disorders. Some people, as I said, dislike this diagnosis very much, others like it. It has become, and this is a fault of mental health professionals, sometimes a derogatory term for people we find difficult. Oh, that particular person is really difficult, they must have a borderline disorder, or worse, we say it about our colleagues. So that's generally frowned upon, but it still occurs. So-and-so, our colleague in the next room, is really, they're so difficult, they're so erratic, they're unstable, they must be borderline. It's an occupational hazard. It's like trying to diagnose people we might want to in a political context. It's very tempting to come up with diagnoses of some people. The significance of the diagnosis is that it's sort of well known in child protection contexts and family law contexts to be one of the conditions, if we use it correctly, that is associated with a whole range of parenting difficulties. And it is a condition where sometimes people are desperately seeking contact, and sometimes for some very needy individuals, having multiple children, even if one fails, is the way to try and do that. So there are these not particularly well thought through approaches and that some people have to try and make up for their own deprivation and abuse. They can be young, they might even have relationships that are pretty dysfunctional but cling together, so that trying to be with someone, and children get caught up in really not particularly good ways. And children are not seen and able to be seen as individuals with their own developmental needs, emotional needs, and so on. So these are the hard sort of cases that quite commonly come across child protection. Now, the reason it's important for children, I won't labour this, I'll just say a couple of things about it, is because the quality of care and attachment and the emotional aspects of parenting has direct effects on brain development, particularly mechanisms of attention, learning, regulating feelings, so-called affect regulation. It clearly affects how children grow up to think about themselves and other people. And this has got great relevance when we think of current debates, social debates, about radicalisation, so-called, of children who are essentially neglected and deprived, which, many of us in this sort of field would find that unacceptable. However, it's a complex issue. It also influences the sort of policy directions that we're going in about punishing children with behavioural disorders, the age of, the criminal age issue, when we're looking at 10-year-olds imprisoned in some areas. These are incredibly complex issues. I'm not saying we don't have to address these awful issues for children, but those are traumatised children who've grown up in many cases in appallingly abusive environments, who don't have some of the fundamentals of self-regulation. They can't deal with aggression. Their attachment is what we would call disorganised attachment, and so on. They don't have that capacity because it's largely been beaten out of them for stability or any feelings of self-worth. And unfortunately, punitive treatment will only exacerbate that. So again, we need a model of thinking about how do we build up these children's attachment security and the ability to actually regulate themselves and take some pleasure in that. And I think solitary confinement is unlikely to be effective. Okay, that I've said. I'll just tell a bit of an anecdote for some light relief of the science as it exists and has grown over the sort of 30 years that I've been doing this, of around early brain development, how important it is, and that it's environmentally sensitive. So as a one famous meeting when John Howard was Prime Minister, when a group of us, and we were all very excited, were invited to go and speak to the PM and various others about child development and why we kept saying, which was true, that we needed to put more investment into early childhood development, protecting children, etc., etc. And, you know, we were rabbiting on. We thought we had our speeches prepared, as we do, but this is very hard to condense down in ways that politicians are going to get messages. So we noticed that there was a bit of sort of yawning, and maybe we weren't carrying the audience in the way we thought was, if we just said it clearly enough, that would be it, the battle would be over. The battle still continues. But then we showed, seeing as we're showing pictures today, and this is a slide from Bessel van der Kolk, who some people might have heard of, who's a trauma psychologist and runs trauma programs, of a brain scan, a child in a normal developmental environment, good enough parenting and so on, compared to a neglect brain. And these were three-year-old children. Now, the thing about a neglect brain is that some of those changes represent the actual neural pathways that are necessary to have appropriate regulation of emotions, coping with stress and so on. So some of the core things are set down in the developing brain very early. So the logic is that if we're going to do something about this as both a social and a clinical issue, is that prevention is incredibly important, that not further traumatising children within child protection systems by moving them between multiple placements, by a failure of systems, both health and social, to really address the issues of these very high-risk families. We tend to put them in the too hard basket. These changes, the brain changes, continue. And so we can see, and that was the thing that the Prime Minister then, Howard, sort of woke up, shook himself. It was like watching Trump at some of those meetings where he's asleep and then he wakes up and says things of some sort. But Howard actually got it. But it was a visual depiction of something. So he asked sensible questions about that. And since that time, there have been, various meetings around early intervention and what it means on both sides of politics, which actually has been helpful. So the children that we see are traumatised, which is really a state where they feel overwhelmed, and they don't have the mechanisms to actually regulate their feelings in that state. Young children, of course, don't often have the language. So we're evaluating young children who've been traumatised in using toys, drawings and so on, and that's quite specialised. The police, of course, are doing that and are very well trained in how to evaluate children, particularly those cases they're seeing of alleged sexual assault. And this is Lenore Ter, who is very well known in this sort of area, and she studied that group of children in America who are captured in their school bus, which got hijacked. And they were put in a cave by people who were going to try and seek ransoms and so on. Now, those children had post-traumatic stress disorder, and some of them were very young. They were preschoolers. So it was very important work that she sort of pioneered, and she's since remained in this sort of area. But there are differences between a single overwhelming event, like being exposed to a hurricane or something. Often what we see that ends up in medico-legal work are chronic and enduring stresses that children face that have impacts on the whole of development. We have indirect exposure, which is children who witness conflict and domestic violence, and some children who even witness fatal assaults on their primary carer, for example. These cases are usually, pretty dreadful. But indirect exposure to trauma, if it can be chronic and enduring, like a chronic domestic violence situation, and those children will have post-traumatic stress type disorders related to that. And other than a single overwhelming event or a natural disaster, so-called, most of these things are transgenerational. If we think about, say, the group of children, if there hopefully will be some survivors from Gaza, those children are going to experience a range of ongoing, really complex mental disorders, and to my knowledge, there's not much because the situation is so uncontained. It's not clear what's happened. But in Australia, we've had a very positive response to quite many groups, including children who've coming from these sorts of areas, and particular ways of working with children who've experienced community-based trauma, as well as what's happened in their own families, are important. So these are the factors that obviously should be noted when we try and work out, well, what's the impact of the trauma? Sadly, and I find this one of these complex and unacceptable sort of arguments sometimes put, is that children don't remember trauma, therefore they can't talk about it, therefore they're not affected by it, the young ones, and therefore they have no claims to having suffered a psychological injury in this condition, none of which is accurate. But I can see where it comes from as that sort of argument. And I think it's important, particularly if for those seeing cases where young children are involved, to actually have experts involved who see young children, or even babies. Babies can show clear signs of trauma. They can be withdrawn. This has been known for a long time. It's not new that we see children who are withdrawn, who fail to thrive. Paediatricians would see quite a few of these as well, so-called non-organic failure to thrive. They're withdrawn, their developmental milestones are impacted. And again, if we don't intervene and protect those children, which means stability of care, removing them from traumatising situations, they're likely to have ongoing difficulties. And down the track, we see children still struggling who might have experienced very early trauma with some post-traumatic symptoms, with nightmares, strange fear-related responses, if things are reminiscent of trauma, and so on. So those are post-traumatic symptoms. They can reenact what they've experienced in play, as they frequently do. So it's having the appropriate clinicians to do those sorts of assessments. So in my opinion, that would be someone who's got child and adolescent psychiatry training, or overseas infant psychiatry training where it's a bigger field. All right, so Lenore Ter, the trauma woman, speaks about the whole range of conditions in both the parents and in children. And she describes the way that people do, of course, try and adapt to trauma. Many adults who've been very traumatised try and avoid things. They can become quite phobic or very, very withdrawn. If you think of some of the war veterans and their accounts of not being able to socially interact, not being able to watch things they would have usually watched, and really cutting off, so repression or dissociation. Sadly, some people repeat. Their current relationships become, really stuck with the same sorts of traumatic themes. We see that a lot. They can be generally anxious, and they're often depressed, guilty and ashamed. Now, that can be an ongoing classification of really ineffectual, in many ways, attempts to live with the reality of what happened, but at the same time not to think about it. So substance use is really important there. Now, won't get through it all, but some of the diagnoses that people working in trauma will come up with are going to be very important in a report that adequately discusses the impact of trauma. So you can have what's called in the systems an acute stress response, which can happen both in children and in adults, post an accident, even or a traumatic, let's say a traumatic injury or surgical experience, or whatever the issue might be. There are obviously going to be acute stress changes. Then the next level up will be a post-traumatic stress disorder, as variously defined. Commonly associated with those sorts of conditions are what we call, in children, disruptive behaviour disorders. So abused children can be angry, dysregulated, impulsive, which really in practice means that they'll end up someone diagnosing them, at least as a clinical observation, with attention deficit hyperactivity disorder. My problem with that is not that I haven't seen children with ADHD, but I think if trauma is known and trauma is seen as a causative factor, we address that first before we think that they should take psychostimulant medication, which has other negative impacts on them. I say the same about adults. But underlying all these conditions, sometimes people will use the term attachment disorders, which in the DSM system is known as a reactive attachment disorder, which is quite a limited description. And for adults, I personally think the use of the terminology complex post-traumatic stress disorder, which is in the World Health Organization International Classification of Diseases, as a label, I think better describes the long-term burden of early trauma on development and development of the self. So it's much more explicit, and that's used a lot more here currently, and sometimes that does come up in cross-examination, which, I was surprised when it first happened, because I didn't know if many people would be interested in it, but it was a good discussion to have, to sort of... All right, then we get to the main clinical part of a lot of these reports, which is to look at the history, particularly of the primary carer or mother, what has happened in their situation. So I'll give an example of a case that is a sort of an amalgam of a couple of different ones, but very similar stories. Many of these parents have significant factors in terms of early development: neglect, abuse. They might have been exposed to their own parents' drug use, which is certainly an increasing phenomenon. Their own parent had them at a very young age, 14, 15. They've had their own first child at 14, 15, and sadly share substance addictions, or at least are getting into sort of more ice these days than anything else. The woman I'm describing came from one of those sorts of backgrounds. Her own mother is said to have a diagnosis of schizophrenia, major psychotic disorder, but uses ice on a daily basis. So that should immediately ring alarms. The mother says, the subject child's grandmother, says that they have schizophrenia, and that explains everything. It's very unclear. It's unclear in the medical records, and I'm not sure how you make a very clear diagnosis of something like schizophrenia or bipolar disorder or any of the big psychiatric conditions if someone's using ice on a daily basis, having seen a lot of ice addicts around the traps. But that's an issue for the various services. They might not have been aware of the drug use. So the woman I'm assessing, she felt enraged at her mother. She felt largely neglected. She withdrew. She didn't develop major behaviour problems that she recalls early on, but she was depressed as a child and was very withdrawn. By the time she was in, and no one noticed this at school, I should have mentioned, which is really concerning, because she was a quiet child. So quiet children don't get picked up as necessarily being abused children as much as angry, aggressive, bad children. So at high school she became more clearly depressed, quite significantly. She didn't want to have any school counsellor or any support, and that wasn't followed up. So no one really asked the question back then, what is happening in this girl's home environment? She developed very severe anxiety symptoms and self-harm and mutilation at a very early age. And again, the questions don't get asked. And she started being involved in exploitative relationships with young men who were particularly difficult. So I think the diagnosis here is worthwhile just unpacking before we even can think about treatment options and what might be available. At the time I saw her, she had not had any consistent care or contact. She found the whole process of discussing what had happened to her very difficult. She did go once to a hospital emergency department, but that's not treatment, that's triage. And if you're well enough to get out, you get out, which was her way of speaking to her. In terms of diagnosis, her main preoccupation on interview was about what had happened to her and why her children, and she was one of the women I mentioned who had 3 children removed, and I was seeing her at 22, and all those children had been neglected by mum, largely as a result of drug use, assaulted and abused by the father, who now had no contact with them, but it was a little bit late for those children. They'd witnessed their mother's out-of-control behaviour when using ice, which her own mother gave to her. So it's a family sort of, it's like sharing a glass of wine at Christmas, really. It's quite shocking when you think about those sorts of very isolated, very remote people who we don't usually access. Child protection have the unfortunate role, and I really value the work that they do of going into these environments. And this was a case where even child protection were taken aback, and they see a lot of an environment that was so disordered in terms of the physical environment, the state of the home. And one young child protection worker, she said, I didn't believe that the animals that go into these sorts of homes, she was from Europe, she was here getting work experience, and I said, what sort of animals? She said, there were rats. There were rats everywhere, and the mother told us that she was breeding lizards. So the whole place was like a zoo, and some animals that sounded like guinea pigs. Horrible, filth, no proper food, no proper hygiene, etc., etc. So, and these people are living in this sort of squalor, and we wonder why they can't think. So the sorts of interventions that we're looking at are not going to be very easy to implement in people who need, in the initial stages, that basic containment, basic stability. If they have children and they can remain sober, if we can encourage them to be involved, they can have some supervised contact. I think these are the cases where the actual planning process is hugely important, and the independent children's representatives do an amazing job in that sort of work, which is not easy when people, if we stress them too much, are more likely to relapse. So on that note, despite it being hard work, I think there's something for those of us who do it really rewarding about being able to we act as a voice for some of these children and others, and women in situations of gross exploitation who have no will left or skills, complex factors to actually, or services to help them extricate themselves from these situations, who see no future without abuse. So it has its upsides. We have our wins in the court, and I do think it's work that we can really focus on to build up more common language about what we're doing, and values, which sometimes get sorely lost in conflict. Thank you very much. Any questions or comments?
Thank you very much. Often I'm an employment lawyer, we have the question of whether borderline personality disorder is actually a disability as defined by the Disability Discrimination Act. Do you have a view on that?
I think I'll give you a mixed answer. Yes, I think it can be, dependent on the severity of the condition and the particular symptoms. Because the way the DSM system, and we have to use recognised diagnostic criteria, but in those sorts of cases, there are multiple ways of having borderline personality disorder. You have to meet X number of criteria, not all of them. So some of the people I see are at the absolute outer edge. Others, and particularly people where we're looking at workplace reactions to whatever might have been a triggering event in a workplace based on their own pre-existing vulnerabilities, can really precipitate a major difficulties that can be ongoing. So it's particularly people, and I've, people with chronic interpersonal incapacity, that difficulty and reflection on their own role and understanding of their own role in these sorts of situations. Yes, I think that functionally that can be a disability without treatment. That then raises the issue of access to treatment. Is it that easy? But yes, I think it can meet those criteria.
In the recent Australian child maltreatment studies, they're showing that the fastest growing group of offenders against children for sexual assault is other children and adolescents. And in New South Wales Health reported to a parliamentary inquiry that there had been a 53% increase in the 8 years to 2024 to referrals for children between the ages of 0 to 10 and 10 to 17 for sexual assault. I just wonder if you have an opinion based on your kind of area of work and the assessments that you do of what is driving this growth.
Again, hard to know. Really, the sort of multifactorial picture, I don't think it's been researched enough for us to know. However, it is a combination of, I think, more cases being picked up, but also I think there are some broader social factors that people are very concerned about. Access to pornography, social media, that's one of the issues that prompted some of the action about, the ban, as kids are calling it, but because they're increasingly prematurely sexualised without the mental capacity, and this is the contentious issue, do they have the mental capacity to understand concepts that many adults don't understand about consent and what it can actually mean? They become confused, anxious, preoccupied, the influence of peer factors. So we've seen some horrendous examples, as you say, so there's no doubt that the numbers have gone up. I think the language doesn't help sometimes. I've heard some commentators talking about child perpetrators of abuse. I'd prefer not to discuss that because these children have either been grossly traumatised and or exploited themselves. But it doesn't mean that the behaviour is not, absolutely unacceptable and inappropriate. I'm not sure that our system knows what to do with it. So some of the, elite private schools where there have been issues of using AI to create sexualised images of girls in the school, upskirting, as it's called, taking, photographs and so on, and then spreading that rating of girls. Now, in terms of, so-called sexual attractiveness in some school environments. So I think the social context is very important as a driver. Now, why some kids are drawn to that sort of behaviour and others are not, if it's associated with violence, I think there are some markers that we have that young offenders, whatever their age might be, if they offend violently, say violent sexual assault against young people their own age or even older people, that usually represents premature sexualisation for them in a violent way. So I think there are a variety of different pathways to getting to that sort of behaviour. What we don't have is the more subtle way of thinking about social response. Yes, banning social media might be a positive thing. It's not going to stop some people. And punishment, again, in a simplistic way, will just, there's no evidence that that's actually going to prevent future behaviour. Any more? Everyone's exhausted now. Yeah. Thank you very much for your attention. I hope that was useful.
Thank you, Professor Newman. That was wonderful. And I just wanted to quickly thank everyone for coming. I know we've gone a little bit over time, but we appreciate everyone attending. Please feel free to stay around and chat to our experts, have another glass of wine, any more food if you like. But other than that, I hope everyone has a lovely weekend. Thank you.